mean, you may not fix it properly. So the moment you put in a needle into the port, you have to see whether blood is coming out. You have to see whether saline is freely going in. So whether you have a port, whether you have a central line, the basic principles you will always have to follow. Chances are less, definitely, but the basic principles you will have to follow. So even, and the residual drug, so if there is a problem with extravasation, you find that there is a problem there, then it should be aspirated from the area of suspected infiltration at the port pocket or at the exit side of the tunnel catheter. So wherever you feel that it has got extravasated, you have to try and aspirate it from there. And most of the time it is very difficult to inject the antidote into the central lines. So you will be generally injecting it into the subcutaneous tissue, as I mentioned earlier. So you will be injecting it subcutaneously wherever you find that the problem has actually happened. So just a few of the antidotes. I will not go into the details of this. This is DMSO or dimethyl sulfoxide. Now this just needs to be applied over the area of extravasation every 8 hours, just lightly, without pressure, without pressing, etc. And it should be allowed to air dry. So that is DMSO which is used there. It is not covered because if you cover it, it may cause blisters. So you just apply DMSO lightly and let it air dry. Do not cover it, do not dress it, do not have tight bandages over it. That's very, very important. We have a tendency of bandaging these areas because we see some redness, some this thing, so let's put some Maxalf and bandage it over there. That should always be avoided, and it should be done for at least 7 days, because it is not enough, because these can have very long-term effects. In fact, in some of the drugs, the maximum effect will come after 2 to 3 weeks. And of course, you need to do it with intermittent cooling, as I mentioned, with ice. The other one, as I mentioned, was hyaluronidase, and that is about 1500 international units, as I mentioned earlier. And it is used in combination with heat in vinca alkaloids. As I told you, in vincristine, vinblastine and vinorelbine, there you need to give heat. Otherwise, for most of the others, you need to give ice compresses. So that's important, and this is the method in which you need to give the subcutaneous injections. That is in a clockwise fashion, small, 0.2 to 0.3 ml, you have to keep injecting in a clockwise fashion, and till the entire area is covered. So, a note of caution which I have already mentioned, this is a very painful procedure because it's already very painful and you are making needles there. So, you must always generally give analgesics before you do this. Hot and cold packs we have already mentioned, and I think there is nothing much more to mention about this here, except these are the details of its mechanism of action. The other things that I would like to mention are corticosteroids and sodium thiosulfate. You know, they were earlier, even they were used. So the moment there is extravasation, you use corticosteroids, local steroids, intravenous steroids. But no, unless there is any sign of anaphylaxis, there is no role today of corticosteroids or sodium thiosulfate. They are almost out in the management of this. Some newer agents are coming in, like dexazoxane in anthracyclines. It's used as a cardioprotector for anthracycline cardiotoxicity. It is also being used now for anthracycline extravasation injuries. Then there are some reports of GM-CSF also being used for extravasation injuries. So these are newer agents which are coming up, but the ones that we have discussed are the common ones, the well-established agents which are used for this purpose. So I think I've already mentioned this. These are some of the names of the drugs. Here we've all mentioned this, topical DMSO. Between 7 to 14 days this should be used. Ice packs. So just repetition being the essence of education, I think, you know. In some drugs, of course, say for example oxaliplatin, or the only liposomal doxorubicin, you know, we use it in breast cancer and it is more commonly used in ovarian cancer. So what is known as lipodox or Calyx. The sister in the gynae ward will know it. If this drug gets extravasated, DMSO is not to be used because it can result in greater damage. So this is the one thing that we need to bear in mind. If it is pegylated liposomal doxorubicin, then you generally do not use DMSO because it can cause even greater damage. In most of the other agents, we can use this. But in cases of oxaliplatin, carboplatin, irinotecan, they are very specific. They are drugs where you don't need to give any specific antidote. The specific antidotes do not really have much of an effect. These drugs are not used very commonly here, carmazine, propamazine, etc. So finally we come to the follow-up and prevention. So the maximum, the maximal ulcer dimension in terms of size and depth is usually evident by 2 to 3 weeks. So this is also important. This is important not just for the sister, I think it's very important for the doctors. Because when they discharge this patient after 3 days, they should know that there is a possibility that things are going to get much worse. So the patients need to be advised to be on that follow-up. Otherwise, they will just give 2 days of ice packs, looking okay, go home. Next time the patient comes, they'll be shouting at you with a huge ulcer over there. So they must be told, you know, this is a problem, this can happen, you must come every 2 days, 3 days, twice a week for dressings, etc., etc. So they, you know, it has to be properly informed. You know, if you inform patients properly, you will have to go to, if you come to the hospital more regularly, you will have to go to the courts less regularly. So finally we come to the preventive strategies now skill of the practitioner. Obviously if it's a very dedicated nurse, dedicated resident, good lines, keeping a good watch, etc. Yes, obviously they will have, as I told you on my first slide itself or second slide, the variation is so immense, 0.1%, 1 in 1,000 to 7 in 100. So it's such a wide range, and for that, you know, that is the area which we need to cover. So it's very important, preventive measures. So you have to be skillful in venipuncture, you should try to go for central lines, try to go for ports if possible. Knowledge, as a little bit which we may have acquired today, very important. Go for the signs and symptoms. Do not depend entirely on signs and symptoms or symptoms. Go for the signs, go to the patients every 2 hours and see. And in fact, before injecting any drug, you must inject normal saline, etc. And in fact, you know, sometimes I've not mentioned it here for lack of time. Sometimes we give bolus drugs. You know, we push in a bolus over 15 minutes. Well, while you are pushing that bolus over 15 minutes also, every 2 minutes, every 2 or 3 ml drug that you push, again withdraw and see whether the blood is coming out or not. That is the way. It is not that you go or sit there and keep pushing for 15 minutes. So every 2 minutes you have to keep withdrawing this syringe and see whether blood is coming or not. Every 2 minutes keep doing it. So that's very important. Similarly, when you are infusing drugs, every 2 hourly you must come and see whether the blood is there or not, or the drop rate is okay or not, etc., etc. Of course, you have to seek assistance if there's a failed venipuncture, etc. Use ports. That's assess for blood return frequently, such as every 2 to 5 cc or hourly for continuous. So every 2 to 5 cc when you are giving a bolus, or every hour when you are giving an infusion, you should go and see whether the blood is coming out or not. Try and use better veins. If you have used peripheral veins, try and use the veins of the forearm. Try and avoid these joints. Try and avoid the dorsum and the foot. They are the most notorious. And patients who are restless, who are having vomiting, lung cancer patients may be having a lot of coughing. So, you know, it depends. So these are patients you have to be extra careful about, because they would tend to extravasate much more commonly. Do not use tissue xylocaine. Avoid joints, dorsum of hand, maintain, aspirate frequently. I think we have been mentioning this ad nauseum now.